So what is target IOP? Why do we need a target IOP? Why IOP? Because in open angle glaucomas, IOP lowering is the only modality of intervention that we have, IOP lowering. So we should know how much to lower. Lowering IOP slows down progression, demonstrated by all clinical trials which have analyzed that, be it the early manifest glaucoma trial or advanced glaucoma intervention study or even the normal tension glaucoma study. Advanced glaucoma intervention study showed that consistently low IOP reduces field loss. In the NTG study, it was shown that only 20% progression in the treated patients compared to a 60% progression in untreated patients. So IOP has to be lowered to prevent blindness. The OHT and NTG gave some guidelines of 20% reduction in the ocular hypertension study, 30% in the NTG study, which were seen that yes, there is no progression or it is lesser. But just these won't be enough. We can't brand everyone as OHT or NTG and say 20% is enough or 30% is enough. There were some target IOP formulas which were proposed. Again, this is not very practical to sit and calculate all this. So therefore, how much to lower, this has to be individualized depending on that particular patient. Okay, we have to weigh the potential benefits and risks of treatment. All medications have their own side effects. We should not over treat any patient either. If you see these, both these discs appear different. Now which one is glaucomatous? One of them may be glaucoma, one of them may be a physiological cupping. So depending on the situation, we may keep a higher target IOP for each patient. So it is basically just an estimate that you are doing of the mean intraocular pressure, which is expected to prevent further glaucomatous damage. You are expecting it to prevent further progression. Whether this is achieved or not will be known only later. To customize it, you need what IOP, the baseline IOP at which damage occurred. Each disc is susceptible to a different level. NTG discs are susceptible to a lower level of IOP, therefore the target may be even lower. Life expectancy of the patient. If it's in a young patient, there are many more years for the disease to progress. Therefore, a lower target IOP is needed. Whereas if it is an elderly patient above 78 or 80, his lifespan may be shorter. So even a higher IOP may be acceptable in such cases. If the pre-existing damage at the time of diagnosis itself is very advanced, then you might need a further lower IOP. Other risk factors like one eye losing vision to glaucoma itself, family history of blindness from glaucoma, other risk factors would make us choose a lower target intraocular pressure. Remember to stage each eye separately when you are trying to figure out a target IOP. The advancement of glaucoma in each eye may be different. This is the Parish classification of how to stage the eye based on visual fields. But not only visual fields, you should look at the OCT RNFL data also and other things like I already mentioned, baseline as well as baseline IOP as well as life expectancy to decide on the target IOP. So these three factors would help you decide. A broad recommendation would be for a mild glaucoma, you set it around 18 or below. For a severe glaucoma, below 13. Below 13, it is seen that progression is very, very slow or next to none. If it's just a glaucoma suspect, then you can even give a higher range of intraocular pressure. This I've already mentioned. So customize your target IOP for each individual patient and individual eye. One eye may be more advanced. If it's secondary glaucoma, pseudo-exfoliation glaucoma, one eye may be more advanced. So that eye may require a lower IOP level compared to the fellow eye. This example here, you're seeing moderate damage. However, it is very near the fovea. So I would put this as a severe damage itself and decrease the target IOP even further. You also should look at the rate of progression on the visual field. Now everybody progresses. It's a matter of how fast each person is progressing. The visual field when you serially analyze, the machine has the software GPA, glaucoma progression analysis, wherein there is a regression plot that is drawn. This was the first field of the patient, this is the latest field. So a regression plot is drawn. It gives you the loss till date, projected future loss in X number of years is given, and how much of the field can be lost. Now if you see, this patient is progressing very rapidly, age of around 79. In the next 2 years this patient can go blind. Definitely a further reduction of intraocular pressure is required. Probably at this stage itself this curve could have been generated if there was some intervention done, either increasing the therapy or operating on this patient. The fields could have been preserved around there, but obviously no intervention was done. This patient has already progressed, wherein the VFI is reached 40. I'll come to the importance of VFI later. So this is how the GPA printout looks. You need 2 years of data for this projection to be drawn. 2 years and 5 fields are minimum. After that, this is automatically generated in the machine. Make sure to ask for this printout, the GPA summary printout. After 2 years and 5 fields, you can ask for this printout. This is drawn for the next few years, and this you can manually project if necessary. So if you see a patient that is progressing more rapidly, you know that you have not reached the target IOP. So target IOP is again dynamic. You set one figure initially, serially repeat, see, look for progression. If you see that the progression is too rapid, then you revise the target intraocular pressure. I told you about VFI. Now this is something you have to be aware about. Once VFI reaches 40 and below, there is disability in the patient's mobility also. So don't wait till 0. Below 40 or 30 itself, patients can have severe visual impairment. Now see this. This is the area of a relative or absolute scotoma that the patient has. He doesn't know what is there. His brain automatically just projects that there may be nothing while there may be something. Okay, so this is what he would think. There's nothing in that area, whereas he might miss out on something. Driving below 30 is definitely dangerous in such cases. So remember, it is a dynamic intraocular pressure. You have to keep reassessing all the time. Initially assess it with time. Once you can monitor his OCT, RNFL as well as fields, and remember to reassess. It can be confirmed only with time. Reevaluate it periodically. You might have to lower the target IOP if you see that there is progress further. Despite all this, some eyes will progress. That is not something you can control. Those are the non-IOP dependent factors. So stage each eye independently and look for progression. Thank you. With that, we come to an end of this talk.